Hello, good morning, everyone. So today we are going to talk about female voiding dysfunction, what are the possible causes of female voiding dysfunction, and how to reach to a diagnosis. Okay, recently this has become a very important topic for your Viva section 2. So let us see who are the patients you need to evaluate for female voiding dysfunction. So any lady who is going to have is presenting with the voiding symptoms for 4 to 6 weeks, you need to think about evaluating her for an underlying voiding dysfunction. Now, it's not necessarily that her presentation will be with voiding symptoms only. When there is an underlying voiding dysfunction, there could be storage symptoms related to it. Okay, or predominantly the presentation could be with a storage symptom. So evaluate if the symptoms are more than 4 to 6 weeks, and underlying causes could be because of a bladder outlet obstruction or because of an underactive bladder. So these are the patients who are going to have voiding difficulties. But then again, as I said, they can have voiding symptoms or predominantly storage symptoms. Now, bladder outlet obstruction can be because of anatomical obstruction or because of functional obstruction. Let us look into that. Anatomical obstruction or functional obstruction. Now, what do you mean by anatomical obstruction? Anatomical obstruction includes intrinsic anatomical obstruction, for example, a stricture or a diverticulum, or extrinsic obstruction like adhesion, stenosis, or post-sling obstruction like an external compression to the urethra, or positional anatomical. For example, there is a prolapse, a cystocele, or a retrograde gravid uterus. So all this causes anatomical obstruction. Patients who are having anatomical bladder outlet obstruction, most likely they present with predominantly voiding LUTs. Patient who has predominantly functional bladder outlet obstruction, they present with storage LUTs. Okay, this is just one of the ways to differentiate, but this is not always the rule. For categorically differentiating them, voiding symptoms predominantly think more in terms of an anatomical obstruction. Storage symptoms predominantly could be any other causes, but functional bladder outlet obstruction, what are the causes of functional bladder outlet obstruction? Could be dysfunctional voiding where the pelvic floor muscles fail to relax properly, or poor relaxation of the sphincter. Primary bladder neck obstruction, and this is when the detrusor is contracting, the bladder neck is not opening. This is primary bladder neck obstruction. And Fowler syndrome is when there is a young lady with a lot of PVR, and this is, we have discussed separately in another video. So you'll find the link in the description. To find the functional bladder outlet obstruction versus anatomical bladder outlet obstruction, you have to consider video urodynamics as the gold standard. So you can reach to a conclusion of your underlying voiding dysfunction caused by a video urodynamics. Our normal urodynamics can help you differentiate between a bladder outlet versus an underactive bladder, but it won't be able to categorize your anatomical versus a functional bladder outlet obstruction. Now, when there are different causes of anatomical bladder outlet obstruction, some of the causes you can just appreciate on your first clinical examination. For example, you can find an anterior vaginal protrusion, which could be a diverticulum with a history of recurrent UTI, and there could be history of sling obstruction. So there's some things you can be able to eliminate based on the history, and a prolapse or something cystocele you can appreciate on your examination. Even a stricture you can appreciate with your gentle calibration. So these are a few things you can appreciate on your outpatient spaces. But if you have an underlying functional cause, you can only differentiate them by a video urodynamics. Now, if you are doing a video urodynamics, what are the findings you can expect? See, bladder outlet obstruction overall are going to have a high pressure. So if you see in the voiding phase, the bladder outlet obstructions, definitely they are going to have good detrusor contractions. So the pressure would be higher. In an anatomical, since there is an obstruction, the patient is going to have higher detrusor pressure to overcome that. And theoretically, they are going to have more high detrusor pressure. Functional bladder outlet obstruction will have also a higher detrusor pressure, but then to a particular level. Underactive bladder, as the name suggests, there would be low pressure, detrusor contraction will be less, and so there will be no or minimal flow. So you can differentiate them based on the video urodynamics. Now, how do you differentiate the different types of anatomical? As I said, based on the examination findings, based on your clinical suspicion, and on the video urodynamics, you'll find that the bladder neck fails to open. It's a primary bladder neck obstruction. You can appreciate in the video the bladder neck opens, however, in the EMG, just after opening, the urethra tapers, and this is because of the pelvic floor muscle contraction, and this is known as a dysfunctional voiding. Sometimes dysfunctional voiding is a diagnosis of exclusion. Once you have ruled out all the causes and you find there is no stricture as well, then this is a diagnosis of exclusion. So dysfunctional voiding, when there is a pressure from the pelvic floor muscles unable to relax, this is dysfunctional voiding. Primary bladder neck obstruction, you should be aware of this main functional causes, and anatomical, as we discussed, find out what could be the anatomical causes. Underactive bladder will have low pressure. Now see, for a male, we have a cutoff for a bladder outlet obstruction index to categorize them into obstructed, non-obstructed, or equivocal. Now, there have been studies to find out what should be the ideal bladder outlet obstruction index in a female, and for that, there is some Nitti's criteria. Now, Nitti's criteria says, we'll just touch upon this quickly. Nitti's criteria says bladder outlet obstruction index for female, they have described with a formula of period at Qmax minus 2.2 Qmax, which is slightly different from the male, which is minus 2 Qmax. So this is taking into multiple factors about the what should be the optimum dead to sub pressure for a female to call it an obstruction. So there are a lot of things going on there. But for us to understand Nitti's criteria, we use this formula. And if the bladder outlet obstruction index in female is less than O, then it's very unlikely that the patient is having a bladder outlet obstruction. If it is more than 5, it is 50% likelihood of having a bladder outlet obstruction. And if it is more than 18, then it is almost certain that they're having a bladder outlet obstruction. Okay, so this is the way we can come to a differential. We should know what are the possible underlying causes, what could be the different presentations, who are the patients you need to evaluate, and how the video urodynamics can help you in categorizing the patients into different groups, because it's very important in understanding the underlying cause. The treatment will vary. You can't offer a treatment of dysfunctional wiring to a patient with a bladder neck obstruction. You cannot offer a stricture the same treatment like a cystocele. So you need to find out the underlying cause so that you can offer the correct treatment. And this only comes when you have all these differentials into your mind, then only you can approach. So in your exam scenario also, keep in mind the differentials, proceed accordingly, and don't just be minded that it could be a stricture, it could be a diverticulum, it could be anything, and then you can have a wider perspective. Okay, thank you. We'll discuss the management in some other video. So stay tuned till then. Thank you.